Hello, good evening, and you're all very welcome. Diagwith, Fáilte Roth. I am not going to expand to other languages apart from English and Irish because I don't have the skills, but you're all very welcome. My name is Regina McQuillan. I'm a palliative medicine consultant and I work in Dublin in Ireland. I work between a specialist palliative care unit and a acute general hospital. You're very welcome this evening to this presentation, which is going to be given by Dr. Sonu Gaind, and it is on behalf of the Drs-say-no International. Drs-say-no International is an organisation which is an international network which has signatories from 20 different countries around the world who are advocating that euthanasia and assisted suicide are not part of medicine and should not be part of medicine. We feel that doctors should be looking after caring for patients to provide care for them. And as a quote from the, 15th century would say that doctors should be curing sometimes, relieving often, and comfort always. Drs-say-no International has a letter that people can sign up to, and we'd hope that people will, if they haven't already signed up, will sign up, and also encourage their colleagues to do so. This evening, we are very privileged to have Dr. Sonu Gaind, who is going to be giving the presentation this evening. He is a psychiatrist and he's professor at the University of Toronto, and his area of expertise is psycho-oncology. He has a lot of experience both as a clinician, but also has, for example, served as governor of the University of Toronto for quite a number of years. He has been involved and has spoken at many of the committees in Canada in relation to assisted suicide and euthanasia, and he has been involved in health policy development and advocacy all through his career. What he's going to speak to us about this evening is in relation to assisted suicide and euthanasia, and the title of his talk you can see there. He feels that medical experts should be involved in developing health policy and should be also then involved in trying to protect people who are vulnerable and protect the most marginalised within society. For the purpose of the webinar this evening, people will be able to hear and see what's going on. All of your cameras and microphones are switched off, but you can ask questions by putting the questions into the Q&A. Two of the colleagues present, John Kleinsman and Sinead Donnelly, they will be looking at the questions, and when Dr. Gaind has finished his presentation, they will be able to take questions from those which have been submitted by the attendees. So I'm now going to hand over to Dr. Gaind, and just to say thank you very much for doing your presentation this evening. Thank you.
Well, thank you, Dr. McQuillan, for the introduction and the framing context, and also deep appreciation to the organizing committee for this kind invitation to speak on this topic. It's a challenging topic, and I think there's no way around that. But what I hope that we get a sense of by the end of this is some of the shared concerns that many colleagues have, I would say from around the world, sometimes ones that have not always been expressed for various reasons. So the title of my talk is Compassion or Abandonment, Canada's Growing Courtship with Assisted Death. And I do start with a bit of a disclosure slide. I don't really have any specific conflicts of interest or disclosures. But because we're talking about policy issues, I do think it's important that people get a sense of both the experience and also the potential biases that someone could bring into a situation where we're talking about sensitive policies. I'm not going to read over all of these things, but I will point out a couple. One is that, as Regina mentioned, my clinical background is in psycho-oncology, also in cross-cultural psychiatry, actually. We called it that before we called it transcultural psychiatry. But psycho-oncology, and I've worked with patients and their families as they've been living and dying with cancer, since residency. I also have chaired my former hospital's assisted dying team. In Canada, we call this medical assistance in dying, or MAID. And so I'm not a conscientious objector per se to all forms of assisted dying in the right context, but I've become increasingly concerned about the dangers posed by our expansions in Canada and some other places. And the last thing that I'll point out is that all of my views, these are things that I'm presenting as my own views in the spirit of academic discourse, not meant to represent any particular group that I have or have worked with. So let's start at the beginning with a whirlwind overview of what's happened in Canada. I'm sure that you've read some headlines on this because Canada's become actually a bit of a focal point of kind of MAID expansion. So the lens has been here for a while, but here's how it came about. Back in 2015, there was a Supreme Court ruling that involved two plaintiffs, Gloria Taylor and Kay Carter, and between them they had spinal stenosis and ALS. Those were the conditions they had. And in that Supreme Court ruling, the Supreme Court ruled that our up until then blanket prohibition against any form of assisted dying in Canada, that was overly restrictive, that breached our charter. And they said that there needs to be some path for people to potentially apply if they were adults and had capacity. That led to Bill C-14 in 2016. And in that bill, we introduced our first assisted dying laws. And that's also when the term MAID, medical assistance in dying, was coined. I'm not particularly proud of this. Canada coined that term. I don't think any country had used it before. And now it's become quite commonplace. I will flag at this point that I actually think it's also become a misnomer in many ways. Because at this time in 2016, when our first laws came in, what it said was that if you had a grievous and irremediable medical condition, which would be defined by something that's incurable, the person's in an advanced state of irreversible decline, and they have suffering that can't be relieved by means they find acceptable. That was also unique to Canada, but I'll get to that later. But if they had all those conditions and their death was reasonably foreseeable, that they should have a pathway to at least be able to apply for consideration for MAID. The reason that I say MAID has now become a misnomer is that at that time, we had this reasonably foreseeable natural death safeguard, which has since been dropped. And so we've now expanded MAID to be providing death to people who are not in the process of dying. So to me, medical assistance in dying becomes a misnomer for those people. In any case, the way that happened was a court ruling in 2019 where, again, two plaintiffs challenged the law as being overly restrictive. One had cerebral spastic paralysis and the other had polio. And this ruling was ruled on by a single judge in a Quebec court, and she deemed that the reasonably foreseeable safeguard was overly restrictive. I will point out that that would not necessarily have had bearing on the rest of the country, because this was a Quebec ruling. But in any case, what the government chose to do, and they were not forced to, but what they chose to do was in 2021, they introduced Bill C-7, which did a couple of things, the main being that it dropped the reasonably foreseeable natural death safeguard, which created what we call in Canada Track 2, where if you are not in the process of dying and you have any medical disability and you're an adult, 18 or above, you can apply for MAID. The other thing it did was at the last minute, the government brought in an amendment to say that mental illnesses would also be eligible, sole mental illnesses would also be eligible for MAID by 2024. Now, I'll get to what happened with that later, because we still don't have that in place yet for a number of reasons. But that's what Bill C-7 did in that year. So what's happened since then? Very quickly, I'll go over the statistics. You might be familiar with some of these, but these are the annual deaths per year by MAID since introduction. These are not cumulative. So when you see the last one from 2022 and that figure of 13,241, that's the number of Canadians that year who received MAID. So you can see that each year it's gone up quite a bit. The data are lagging. So this is 2022. We have the 2023 data as well. The reason it's not on this slide is because Health Canada changed how they actually present this information. They no longer provide this chart. But if I was to draw it in, that's what the number would be for 2023, over 15,000 deaths by MAID. To put it in a different context, this is what's happened over the years. These are going to be a series of charts I go through very quickly, but the red line shows the national average death rate by MAID, and the blue line shows the different provincial variations. And what you'll see is that every year, Quebec, which is in the middle, and BC, which is on the far right of your screen, they've always had higher rates than all the other provinces and then the national average. And that trend has continued. But in 2019, 2% of all deaths in Canada were by MAID. It went up to 2.5% the next year. It went up to 3.3% the following year. And then it went up to 4.7% in 2023, which again, I have to draw in because Health Canada no longer provides this graphic in their reporting. So that's what's happened with our numbers overall. Just to summarize the key changes that happened in 2021. We had two pathways created. One, if death is not reasonably foreseeable, and that's track 2, which requires a 90-day or 3-month assessment, which is not a reflection period of the patient, by the way, but from the assessor feels that they started their first assessment to the last. And the mental illness piece was supposed to come in till in 2024, and that has been delayed at this point till 2027. I put at the bottom here, unique to Canada. This is no longer unique to Canada, but at the time our laws came in, we had no requirement for treatment or even access to treatment having been necessary prior to someone getting made. They just needed to have suffering that they found intolerable, which is purely subjective, and not relievable under means that they found acceptable. Up until then, every other country, including the ones in Europe that in other ways had a bit more liberal assisted dying laws, they still required that people have gone through at least best attempts at treatment prior to getting assisted dying. Canada did not and does not require that. So let's get to the bulk of the talk, which is this. You know, I think that our path to our MAID policies has not been a sound one. It's not your usual yellow brick road. It's been much more of a broken road, and I'll explain why. How did we get here? So the bulk of my talk is going to be a series of sections on this part 2 of troubled waters and how we got here. And the first is looking at, you know, when you introduce national policies, you kind of hope that there's robust consultation and reasons for doing so, evidence-based, or that you're legally required to. So let's explore that. Because as I pointed out, the expansion in 2021 to drop the reasonably foreseeable death safeguard, that would not have been binding outside of Quebec. There are some unique elements within Quebec as well, but unusually, the federal government chose not to appeal that decision, and instead they implemented Track 2 nationally. There's a group of scholars that wrote to Parliament and wrote to Cabinet, pointing out that Parliament was not forced by the courts to expand, and certainly not to expand to MAID for mental illness as they planned to. In fact, no cases of mental illness were before the courts in the cases that have set our laws, Truchon or the Carter case. And in terms of the process, I won't go into the details here. Suffice it to say that the process was highly political. It was along partisan lines, essentially, that the expansion passed. And the interesting thing here that I will point out is that there were attempts to prevent the further expansion, and those were things that both the parties on the left and the right unified about. So both the Conservatives on the right side of the political spectrum and the NDP and the Greens on the left side of the spectrum thought that expansion to mental illness should not happen. Now, in terms of the consultation piece, I had been asked to talk a little bit about the role of medical and psychiatric associations. That's reflected in some work that I've done in a chapter in a book we published with several colleagues. And so I'm going to spend a little bit of time on this because I think it's important for people to realize that the input of our associations has an impact, but it also should come with a responsibility. So here's an overview of some of the key input from the Canadian Psychiatric Association, which I am a past president of, but no longer a member of over this issue. In 2020, they released a position statement with no input from membership. Membership didn't even know they were developing a position statement, saying essentially that patients with psychiatric illness should have available the same options regarding MAID as everyone else. They framed it under the context of discrimination. And when they got some blowback from that, from myself and others, pointing out that, you know, how did you come to this position? And how do you even know when mental illnesses won't get better, when they're irremediable, which is a key requirement for our MAID laws? CPA quite remarkably responded that while our statement was never intended to examine whether psychiatric conditions are irremediable, and if so, how this should be assessed. In my view and that of many of my colleagues, that's putting the cart before the horse. In fact, it's doing so before even knowing if the horse or cart is there. And despite this, they continued to say that, well, we're neutral, we haven't taken a position, while at the same time repeatedly saying that not providing MAID for mental illness would be inaccurate and stigmatizing, vague, arbitrary, overbroad, discriminatory, and constitutional. So, words speak for themselves. And in terms of irremediability, what we know from the evidence is that we're terrible at predicting irremediability of mental illnesses, even in things that are as seemingly straightforward as treatment-resistant depression. There's been work done with sophisticated modeling showing that we are right 47% of the time when we try to make predictions of irremediability. That literally means you would be better at flipping a coin to tell a patient whether or not they are in an irremediable state from a mental illness for which they could apply for assisted dying from. Highly problematic in my mind. The interesting thing is that some of the groups that actually have advocated for expanded MAID and for MAID for mental illness, they acknowledge that irremediability is not predictable. So the Quebec Association actually acknowledges that the person could have regained the desire to live at some point in the future. And their answer to that, I find this remarkable, their answer to that is that, well, assessors will have to answer this ethical question each and every time. When we put on the white lab coat, we do want to be ethical, but the white lab coat confers a medical expertise that we should be providing to society and to patients. And our laws don't say, and the public and kind of premise has not been, that a condition is grievous and irremediable medically if that's the ethical opinion of an assessor. So you see that these things can be problematic. As time went on, there were increasing concerns raised about the expansion to mental illness, and there were groups that started to challenge whether that should happen, including actually the chairs of our university departments in 2023, and other groups I'm involved in, the Society of Canadian Psychiatry, a fledgling group. And even then, when the CPA was asked about this, was a delay necessary? The president at the time, Gary Shemowitz, continued to say that, well, the safeguards that are embedded in our view protect all vulnerable Canadians, and framed that if there were other things that were specific to people who have a mental disorder, that would be discriminatory. And in parliamentary hearings, the idea was presented that, well, mental illness, it's like everything else. When questioned about, well, do we actually have enough resources for providing mental health care? And do we have enough resources for providing even the assessments required for MAID for mental illness? The CPA chair, Alison Freeland, responded, well, we don't have enough resources for all kinds of things that we do in the delivery of mental health care. And there are lots of examples where everyone's not part of a new thing that comes out. This to me was pretty remarkable because it basically presented that, well, providing assisted death for a mental illness, it's like other things we do, like TMS or psychedelics, as you can, or psilocybin treatment, which I don't share that particular view. But that was the input. And the concern about that is that that input does shape policy. In my view, we do have to acknowledge that mental illnesses are legitimate illnesses. That's what we fought against in terms of stigma and discrimination for years, to ensure that our patients' experiences are legitimated by society. Mental illnesses are legitimate illnesses, but it is simply false. I actually think it's disingenuous to claim that they're the same on all issues related to death seeking and MAID while actually ignoring the evidence. I've termed this Pinocchio syndrome, wanting to be so much like a real illness that we end up saying falsehoods. And as I said, these things do inform policy. So the senator, who's also a psychiatrist, Senator Couture, who introduced the bill to expand MAID to mental illness, heavily quoted both CPA and the Quebec Association testimonies and consultations. So on the first pillar here, the consultations, in my view, they were deeply flawed. They were informed by a lack of evidence, and there's also no legal requirement in Canada to expand MAID to certainly not to mental illness. So what's next? Well, this is a fundamental question. Can we separate expanded MAID from suicidality? We've essentially been assured that we can, that don't worry, if we're providing MAID, it's not suicide. Let's have a look at the evidence behind that. And this is where the waters got even a little bit more troubled. Because is that evidentiary or is that or is that simply ideologically based? We've had strange messaging right from the top. So the first phrase here is from a former Minister of Justice who on one Fifth Estate episode on CBC actually acknowledged that MAID is a species of suicide. He never used that phrase again. So it came up that one time, and I have not heard it from policymakers since. But around the same time, the former mental health and addictions minister, she, in trying to reassure people that MAID and suicide are different, she said, well, assessors and providers for MAID are trained to eliminate people that are suicidal. That might be one of the most telling Freudian slips that I'm aware of. It's a poor choice of words. I do understand what she's trying to say. What she's trying to say is that, well, we filter suicidality out from MAID assessments. But let's have a look at that. There's been shaming messaging about this. So the same senator who introduced the proposal for MAID for mental illness. I was at a psychiatric congress in the Atlantic provinces a few years ago, and to a room full of psychiatrists who were expressing concern about, well, how do we separate suicidality? Like, what is the difference between somebody seeking death with a MAID assessment versus the traditional suicidality that we try to assess? He basically said, well, if you don't know how to do it, you're incompetent. My goodness, colleagues, it's a core competency at Royal College standards. If a psychiatrist can't assess suicidal intent, you're telling me you don't have a core competency. I actually turned to the person sitting beside me and said, I'm a former president of the CPA and the OPA, and I think I lack this competency. Maybe I need to go back to residency training. In terms of the actual input in the constitutional hearings, this is quite remarkable. Think about this for a second. The number of times in the Senate hearings that we're talking about expanding MAID and that we're talking about and got to MAID for mental illness, the number of times that anything related to suicide, whether it was suicide risk, suicide prevention, or any variant of the word suicide, suicidal, any variant mentioned by the Canadian Psychiatric Association in all their written and oral consultations on mental illness and death was zero. That's remarkable. Just think about what it would mean if a respirology association refused to ever mention smoking as a risk factor for public consultations on lung health. It should raise some concerns. And if you look at the actual way that assessors in Canada are being taught to supposedly filter out suicidality, these are excerpts from the Canadian Association of MAID Assessors and Providers, CAMAP. It's from their mental health module, and they have a section on it which is meant to help distinguish suicidality. It's a section that has 10 slides with content. They say it takes about 10 minutes to go through, and that includes a 4-minute video. The kinds of things that are in it are, I'm not sure what some of them mean. So managing suicidality is something most clinicians learned at some point. The general principles apply in the MAID context as well. That doesn't tell you how to distinguish what we've always assessed as suicidality from a MAID request. When you get down to the more specifics, look at the specific things that are suggested to be asked. They talk about the specificity of the plan and what the person will do if they're not eligible. And there are 5 questions here. I could answer every one of these 5 questions if I'm seeking a MAID assessment in a very similar way. So I go to my MAID assessor, and the MAID assessor asks, are you having thoughts about suicide or ending your life? Do you want your life to end? Yes, that's why I'm here. I'm seeking a MAID assessment. Do you have a plan for how you would end your life? Yes, I've come to you for the MAID provision. Do you have what you need to carry out your plan? I don't, but doctor, you do. The injection you'll provide me. Have you set a time to go through with your plan? Well, that's when we're going to schedule it. And what keeps you from acting on these thoughts? I'm going to wait until I get my MAID provision. How does that distinguish traditional suicidality? It simply does not. And essentially what they're being taught is that if the person is wanting to end their life themselves or exhibiting impulsivity, then it's the traditional or quote unquote bad suicidality. And even that's not accurate. We know that most completed suicides in North America are not impulsive. They're planned out. And even the phenomena of buddy suicides is something that's emerging in different parts of the world, where people go and deliberately plan to end their lives together with someone else who is also ending their life. So it doesn't actually make the distinction that it claims to. I pointed this out and have continued to point this out a number of times. In terms of the reaction, it's been quite interesting because the parliamentary report that came out, which I'll get to later, that suggested we do not go ahead with expanding MAID to mental illness. They quoted testimony from me and other colleagues. And the senators who wanted expansion actually took target at me and used their national platform to say that I may have misled the committee, that my testimony led to a discrediting of Canada's medical education accreditation process, and essentially that it could have destroyed medical education in Canada because I raised questions about the lack of evidence informing CAMAP curriculum. And so essentially the message that I think many are being told is that if it's made, it's not suicide, but it's not really based on evidence. To me, it's more of a Jedi mind trick. You know, these are not the droids, or sorry, the suicides you're looking for. It's kind of ironic that, you know, Canada became the first place in the world to start printing warning labels individually directly onto cigarettes. And yet, what we are doing is giving false reassurances that MAID is never suicide. So we become the first country where every cigarette will carry a caution, warning may cause premature death, and every syringe a reassurance that don't worry, psychiatric euthanasia is not suicide. So in my mind, that pillar also falls. There's a lack of clarity or evidence that MAID assessments can filter out suicidality. If anything, the evidence speaks to the opposite. And then the last part of section 2, what are the consequences, ramifications of this? And especially, are marginalized populations at risk? So what are the implications? And can I pretend this is just about autonomy and dying with dignity? Well, let's look at this, because assisted dying has essentially been presented as purely an issue of individual autonomy, and that singular issue drives through policies. If we look at autonomy, when we look at people who get psychiatric euthanasia in Europe, in the few places that have allowed it, what we find is that when assisted dying is provided for end-of-life conditions, people do tend to come from higher socioeconomic privilege. However, for psychiatric euthanasia, there are unresolved psychosocial stressors, lack of socioeconomic resources, and different types of suffering. So in my mind, that's actually a privileged autonomy versus a false autonomy that we're setting up. It's not everyone's autonomy is the same. We don't all have the same autonomous choice. When we looked at whether we could separate suicidality from psychiatric euthanasia on the Council of Canadian Academies, I sat on this expert panel. We looked for 18 months, a year and a half, at the evidence across the world, and we couldn't find that these things could be separated. In fact, we found overlapping characteristics between people who get psychiatric euthanasia and traditionally suicidal populations. You find the same thing if you look specifically at data from, for example, the Netherlands of people who get psychiatric euthanasia. You lose the gender parity. When assisted dying is provided for end-of-life conditions, typically you have gender parity, as many men as women get it. However, once you expand it beyond end-of-life conditions and you expand it to psychiatric euthanasia, you get twice as many women as men who seek and get that assisted dying. And you also get the emergence of social isolation and other psychosocial risk factors. Particular thing I'll point out about this 2-to-1 ratio of women to men getting psychiatric euthanasia is that that actually parallels the 2-to-1 ratio of women to men who attempt suicide when mentally ill. Most do not die by suicide, and most do not try a second time. So the obvious concern is, are we converting transient suicidality in some of these situations to a permanent death by MAID? And if you look at the type of suffering that leads to psychiatric euthanasia, again, to me, this is not the same autonomy as you or I might have when we're making our decisions from our privileged perches. But you see suffering that's fueled by failures to live up to expectations, feeling a burden, and getting to a culmination point from multiple misfortunes. We know that suicide, completed suicide, is not just a mental illness issue. It's also a social disenfranchisement issue. So Indigenous populations across the world and other marginalized groups, LGBTQ two-spirited, etc., have higher rates of completed suicide. And the Indigenous suicide rates they were not high before colonialization. So it's not that it's just natural, and it's not that it's just mental illness. It is also socially driven. And that leads to the concern that marginalized populations, in my opinion, are more at risk of life suffering and lack of access to care, all of which can combine to fuel the suffering leading to death. So for the last part of my talk, before I get to the last part of this part, part C, looks at the marginalized populations. What have we seen in Canada? Well, we have seen people who literally say, I will die when I run out of money. We have seen people who have applied for and gotten assisted dying for things like chemical sensitivities. And when they get it, 51-year-old woman, she gets it after a desperate search for affordable housing, and after that failed, and says, government sees me as expendable trash. There are other cases where on the left of your screen, Winnipeg woman with medical assistance that struggled for home care helped lead to the decision, saying it wasn't a genetic disease that took me out, it was a system. Ontario woman with long COVID begins the process saying MAID's exclusively a financial consideration. This is a heartbreaking story. This was a fellow from Quebec, Mr. Monnier. He was quadriplegic. He was living at home. His wife was looking after him. He didn't want to die. He got a respiratory infection, was taken to an emergency room in a Quebec hospital. While in the emergency room, his wife was pleading with them to get him a pressure mattress or at least turn him frequently. Neither of those things happened. So over the course of 3 or 4 days, he developed severe bed sores to the bone, incredibly painful. And he knew that that would take a long time even to treat and be painful for a long time. He chose MAID. CBC interviews him the night before he gets MAID, and he's in tears. This is not the picture of autonomy that we've been promised. The thing that I find particularly disturbing is that there are still groups from a very privileged position that deny all of this. Dying with Dignity Canada to this day labels it a myth that vulnerable populations are at risk. Now, there is a caveat on this slide. This actual screenshot I have here is from earlier. They had this for years, saying myth, vulnerable populations can be eligible for MAID if they are suffering from inadequate social supports, including housing. I challenged this for years. I actually had a debate with, I think, a Dying with Dignity board member earlier this year. They changed one word in this. As of early 2025, they now say vulnerable populations can be eligible for MAID because they are suffering from inadequate social supports, including housing. So that is now the myth. Think about what that means. Even that is telling, perhaps a little bit of a sign of insight that they no longer claim that people can't be eligible if they're suffering from this stuff. And what does the data show us? Well, this is what I'm going to wrap up on some of this evidence. And I've got some very good colleagues who've helped bring out some of these issues sitting on Ontario coroner death review committees. But we've had now some reporting, both from Ontario and nationally, that looks at quintile-based marginalization, meaning just like we did in COVID, we split the population into quintiles and look at the most marginalized versus the less marginalized quintiles. Each should be 20%. That's a quintile. This is done based on geography and postal codes. When you do that, what you find is that, especially on track 2, there's a disproportionate number. So look at the graph on the right, disproportionate number of 28.4% coming from the most disenfranchised material resource dimension. Again, everything else being equal, these should all be 20%. When you look at the housing and dwelling stability dimension, goes up to almost 50% from the most marginalized, and it goes to nearly 60% when you look at the age and labor force dimension. What we're also seeing in the data emerging is that there's a very high percentage of people who express suffering of feeling a burden and suffering of feeling lonely and isolated as fueling their MAID requests. Nearly half of all on track 2 say that those are significant sources of their suffering. And we're also seeing a gender gap emerge on track 2 and other nebulous other conditions. Other means it's not cancer, not respiratory, not cardiovascular, not neurological, nebulous other. We're seeing a gender gap of more women than men getting MAID for nebulous other conditions and for track 2. So all concerning things. I've presented on this at other congresses internationally. I'll leave this up just for a second, free to screenshot if you wish. But here is something where I've compared what CDC's suicide prevention strategies on the left side are compared to Canada's current MAID regime. I had to pick CDC because Canada still does not have a national suicide prevention strategy, yet we've gone full steam ahead with our MAID expansion laws. But if you compare and contrast these two columns, just think about what some of this means, because it's not all about illness. It's also about the social environment and living situation of people. And the very factors that we know put people at risk from a socio-economic and psychological standpoint, at risk of suicide, that we normally have tried to help with and provide suicide prevention. Those very same factors, we're actually seeing them come into play for people who are getting MAID in some situations, and unfortunately more situations than we should be comfortable with. So in my opinion, we have gone from laws that initially started to compassionately relieve end-of-life suffering to also providing socially facilitated or even enticed death to escape life suffering. And so that last myth falls about suicide. And in fact, I think that marginalized populations are at risk. And I would actually suggest it's suicide denialism to ignore or deny that. So what do? I don't want to leave this on a downward note. Path forward. Well, first, Canada is not a shining beacon on the hill here. We're a canary in a coal mine, or our patients are the canaries, unfortunately. But Canada is a cautionary tale. I think we need to be open about this. I've written about this extensively for years. But in my view, expansion might be safe for privileged who already live well, and like me, who'll have more autonomy to die better. But for others, non-dying disabled and marginalized, whose social suffering will be solved with death, it will eventually be called something else. I fear we are setting ourselves up for the next national apology. These are some more recent things. So some of the statistics I presented on the Ontario Coroner's Report, you can see that in the top reference here, MAID and marginalized people, coroner's reports in a piece in The Conversation, and then a piece in American Journal of Bioethics, because I do think that there's a cultural and privileged element here to these narratives. So a white senator, doctor, and lawyer walk into a bar and appropriate the assisted dying narrative. It's an open access piece on AJOB with the link there. So I think what we really need to do is ask the right question. The right question isn't even, are you for or against assisted dying in many ways? Some of our jurisdictions have assisted dying laws and no doubt will continue with them. But I think the question is, which mistakes do we want to make with those laws, or which are we willing to make? And we need to be honest about what we're providing death for. And in that context, there are things we can do. I think we need to have respectful debate, avoid false conflation that assisted suicide is the same thing for everyone. It's not. It affects marginalized groups very differently. We contribute evidence as experts. That should be what our obligation is, not just our personal ideologies. Also, don't succumb to debate stifling. People have been challenged saying, well, don't even use the word assisted suicide. That's pejorative. Don't use the word euthanasia. Those aren't pejorative terms. They're actually factually accurate. It's not biased to use them. It's interesting. I've been chief of psychiatry here at Sunnybrook for nearly 3 years, and I have continued to speak on these topics. And what's interesting is that when I've done media pieces, there's generally been the preference that I identify myself as a professor of psychiatry at the University of Toronto, rather than any role at Sunnybrook. I'm actually stepping down from that role at the end of this month. But it is something where it's been challenging for other people often to actually have discussion of concerns. And part of the reason is we've had what I would call a bit of a learned helplessness, and debate is over debate suppression. Again, the same senator who actually introduced the MAID for mental illness expansion, he would repeatedly say for a number of months to years that, well, the debate is already over. It's already been decided. Policy is over. Now, at the risk of spoilers, for those of you who haven't seen any Marvel Universe movies, when we think things are inevitable, so Thanos had this idea that things were going to be inevitable. What we know is they don't always turn out exactly the same way that we think when there is inevitability. And we have seen changes here in Canada as concerns have become expressed and more widely known. And while I would say it is an uphill battle often, I choose a different narrative here, which is that resistance is not futile. I think that there's proof in the pudding. These are links to some testimonies from the most recent parliamentary testimonies that led to our latest national report. And that was the one that, in fact, suggested that MAID should not be expanded for mental illness, that it should be paused indefinitely. The government chose to pause it only for 3 years. So that's why we have till 2027. But still, the testimony of evidence did have an impact there, and you can see the actual report here. There is currently a private members bill that's going to be heard probably before the end of the calendar year in Canada. I think it's private members bill C-218, which is seeking to prevent this expansion even in 2027. We will see what comes of that. And then the last slides, I'll just pop up this reference if you have interest. This is a book that was edited by myself and two very good colleagues who I hope may even be on the meeting link today. But it's about our experiences of MAID in Canada, unraveling MAID in Canada. And I'll leave the link up for a second. There is a QR code for this on the last slide as well. And I had promised at least 15 minutes of discussion. And with that, I will wrap up and turn it back to you, Regina, for opening it up to the floor for discussion. And thank you very much for your attention, everyone.
Thank you very much. Very interesting presentation, and great to see the research you've put into this and the consideration you have given to it. So I think there was a question early on. This webinar is recorded and will be available. Just clarifying that, Sinead and John. Yes?
Correct.
Perfect. Okay, that's great. Excuse me, because I say you have some very interesting information there. I might start myself with a question and then maybe hand over to Sinead or John for other questions that come in the Q&A. Excuse me. The results for sort of marginalised people, particularly for track 2, and who seek and get MAID, has that evidence had any impact in wider society? Is this something that people are concerned about? And I'm asking that question because I know there was one of those public polling things done in Canada quite a number of years ago, and asking the public should assisted suicide be expanded. And something like, I think of people under the age of 25, 48% said it should be expanded to poor people, and something like 49% said it should be expanded to people who have no housing. So that seemed to be the way young people thought they should be eligible criteria. But is this a thing that causes any degree of concern at all that you're aware of in the sort of public domain or public discourse?
So I'll answer in a couple of ways. I'll start by saying, yes, I think it has started to generate more concern. It's harder to get traction on that for a number of reasons. One thing is that when our MAID laws came in place in the first place, it was essentially under the cover of COVID in many ways. So if you think about the timings, 2020 moving forward, 2021, people were focused on other things. Once laws get into place, people tend to extend they confer a degree of legitimacy to them and think that, there must be a reason that they came in. And what I will say is that as these other cases have emerged, there has been increasing concern, both in the public, I would also say amongst policymakers. I think some politicians are less sure of whether expansion is a good thing or not, and also in the media. And the other thing that I'll point out is that in response to polls, it's really important to understand the context of some of those polls, because in my opinion, some of those polls can be quite misleading. You're absolutely right that there are some people who think it's okay to provide assisted suicide for social conditions. There were 2 University of Toronto bioethicists, of all things, who essentially wrote a piece saying that they considered it harm reduction, that if somebody is in a state of poverty or other social suffering, who are we to deny them MAID? And, it's harm reduction to provide them MAID if that's the one. I'm thinking, well, that's not the harm I would try to reduce. I'd try to reduce their poverty rather than providing death. But in any case, There is some small group that may believe that. I don't think most believe it. And the reason that I say this is that the context of the polls like that is often not fully open. And if you look at, so for example, Scott Kim and colleagues, they did a piece in British Medical Journal Open, where they asked people, do you support Canada's MAID laws and expansion, et cetera, et cetera? And about 2/3 of people did. Then they provided actual examples of, would you support it in these situations? And about 2/3 of people said, no, I wouldn't. And yet all of those situations are things that our MAID laws allow for. So I think that it's always important to take those survey results with a grain of salt, especially if they're ones that have been commissioned by Dying with Dignity or other groups that have actual stake in the game.
So there's a series of questions from participants. John, I'll just start with the first one. So it's from Dr. Mark Comrade, our colleague on this committee as well. The question to you, Dr. Gaind, is, has the Canadian Psychiatric Association explicitly said that MAID is not a form of suicide and should be considered as something separate, like the American Association of Suicidology once officially maintained but has since retracted?
So as far as I'm aware, they have not said that, Mark. I'm no longer a member, so I don't get all of the communications, but as far as I know, they have not officially said that. What I will say on your last point about the American Association of Suicidology, I've still been to congresses where some people, when they talk about expansion, they continue to quote the old AAS position that they rescinded a few years ago, but the one that you're alluding to, where they said that they're distinct. And I know that position is no longer one that they have publicly, at least.
There's a question here from Catherine, who's asking about how we can, or how we might be able to convince politicians in other countries, talking about Canadians, I guess. We present evidence about MAID in Canada to politicians in other countries such as the UK and France, and they often reply that their country is different. It won't happen like that in our country. Canadian politicians said the same thing about data from the Netherlands and Belgium before the Canadian law was passed. How do you respond to that? How might we respond to that?
Well, so I think that on one hand, the evidence speaks otherwise, because what we actually see is that things do cross borders, right? So some of the things that have happened in Canada that were more expansive than other jurisdictions are actually now looking at those. I think Dr. Comrade had sent around something recently about Uruguay's plans, for example, and that would have been virtually, I think, unheard of 10 years ago before Canada's laws were in. So each jurisdiction that has more expansive things, others actually do look to it to say, well, it's a human rights issue, and so we need to provide it. It's a lot more than that is the thing. So how we convince politicians, I will say that I think there are some who may not want to be convinced. And that's something where we can't change ideological minds necessarily. But the people who are sitting on the fence, the people who actually are open to evidence, I think we have compelling evidence emerging that shows examples of clear marginalization risk. And one of the things that is particularly compelling in there is the gender gap, right? Because that is something where it literally is, it's a dichotomous thing. And that's very powerful. And what else in medicine? Is there anything else in medicine or social policy that a politician would say, oh, I'm just going to ignore the gender gap? It's almost unheard of. And yet in our parliamentary hearings, the psychiatrist who had been tapped by the government to chair the MAID and mental illness work, she herself is quite a staunch expansionist. When she was asked about this gender gap in parliamentary hearings, she literally testified about whether it concerns her. She said, no, it doesn't concern me because I don't think anyone knows what it means. A remarkable answer. But I think a lot of politicians would be hesitant to give that answer.
Thank you. There's another question from Joanne Wright. Thank you for your excellent talk. And given that a high proportion of medically ill patients have mental illness of some sort, often depression, demoralization, anxiety disorders, how does this differentiate ethically MAID for track 1 patients from track 2? Suicidality is still impossible to differentiate from rational suicide in this population.
And, Joanne raises an excellent point. I agree with everything you said there. And what we are seeing is that even within our existing laws before expansion to MAID for mental illness, both on track 2, but even some signals on track 1. The idea of what's actually fueling that person's wish for dying kind of gets obscured, right? So we go back to the big picture data saying that, well, most people are getting it for things like cancer and respiratory, et cetera, et cetera. What we're not tracking is what was your individual source of suffering that led you to seek this? We're not doing that. Even the data I showed you, those are geographic-based proxies. If we actually want to understand why people are seeking death, we need to ask them. And if we want to try to separate traditional suicidality, we need to know that we can do that. So what I would say there is that all of those same risks actually do come into play there. But one way to potentially think about it is this, that areas that have much more restrictive, by that I mean limited laws, they, at least up until now, do seem to have been able to avoid some of the scope creep. So for example, California, they introduced their laws around the same time Canada did. And it has a similar population within margin of error, so to speak, as Canada. Rather than 15,000 assisted dying deaths by 2023, I think they had a few hundred that year. A world of difference. And it does make a difference about whether it is something where somebody, for example, is predicted to only have 6 months left to live. And the reason it makes a difference is twofold. One is that whatever else is going on, there may be other confounding factors too, even in those populations. But you also know that the person is on a trajectory for dying, number one. And number two, the suffering related to that trajectory is also going to increase. In other words, the balance of suffering in some situations very close to death might be different. But Joanne makes a good point that the actual risk factors, how do we separate those out? I don't have an answer for that.
So there is a question here about suffering from Jamie. My concern is that expanded MAID makes suffering abnormal. Suffering, in fact, leads to a healthier society in that it promotes empathy and active compassion for those less fortunate than yourself. Do you agree with this broader concern?
Absolutely. Look, suffering is part of, I'm not suggesting that we all want to suffer. That's not how I mean it. But suffering is part of life. And the way we deal with that is also part of how we should be interacting as a society. And we all know that story of the boy in the bubble type of thing. You protect somebody too much, and that's actually not necessarily a healthy thing. Similarly with suffering, if our reflex reaction is, oh, we're going to help you by eliminating your suffering, by ending you, what message is that sending? It's a very different kind of message. And that touches a little bit also on the issues of what is found to be acceptable or not, right? So in suicide prevention, we have those concepts of things that can either promote more suicidal thinking, so the Werther effect, versus more protective thinking, the Papageno effect. Which side do we want to be on? Because these policies do play out in that kind of sphere as well.
Thank you. Another question from Dr. Comrade. What is the current status of conscientious objection by clinicians regarding MAID? Not just refusal to do it, but refusal to present it as an option. How allowed is it both legally and ethically? And then, is the Delta Hospice incident indicative of what is happening nationally on a wider basis?
So there's been a bit of again, a lot of this comes down to sometimes a bit of an ideological drive one way or the other. And there has been a bit of an ideological drive to ensure that everyone is aware that MAID is an option, so to speak. The reason I say that is that the standards that were released this would have actually been by Health Canada. They were developed by half a dozen people, which included among some of the most vocal proponents of MAID expansion, by the way. But those standards essentially talk about the need to refer effectively. And that means that if you are a quote unquote conscientious objector, you still need to refer your patient to somebody who will tell them about the option for MAID. They go much broader than that because there are actually licensing bodies who've pulled that in as part of what they require. So it's not just a vague policy. When licensing body says it, that can have different implications. And in terms of conscientious objection, it's quite remarkable because they've gone as far as to say that even if you aren't an overall conscientious objector, so to speak. So even if you agree with MAID in principle, but you think in a particular case, it would not be appropriate because, for example, the person hasn't had access to treatment, for example, then you're considered a conscientious objector for that case, and you need to make an effective referral to anyone who could be eligible. Anyone who could be eligible literally would mean pretty well any adult with a disability who gets admitted to a hospital. Because how do you know if they're in a state of intolerable suffering if you don't ask them, for example, is what the argument would be. So it is a concern. Yeah, it's an ongoing concern.
And there's part of the question was about the Delta Hospice. Do you understand that query that came from Dr. Conrad?
So I'm aware of elements of the incident, but I don't want to miss, because there are delicate situations there. So what I'm going to suggest is people just do either a Google search of it. It will come up. You will see. Okay.
Thank you very much. Thank you very much. Okay. John or Sinead, any further questions we want to raise?
Yep, John.
So Andy has a question. There are economic arguments supporting MAID, especially for the most disenfranchised, and you've touched on that in your presentation, Sonu. Are you aware of compelling economic counter arguments?
Yeah, so, the thing with the economic arguments, I started my talk with a disclosure slide. We usually do that in academic settings. And what I have yet to see is in any policy setting, kind of a policymaker or politician issuing a disclosure that, oh, and by the way, there might be a conflict of interest because providing MAID is a lot less expensive than providing care for a disabled person in an ongoing way, or providing socially supported needs for a disabled person in the community in an ongoing way. And we actually have had some work done here in Canada, both before our Track 1 opened, the initial laws, that estimated savings of, I think, $40 to $50 million a year at that time, based on the initial laws. And then some projections that were done by the Parliamentary Budget Officer of what the savings would be, or what the implications would be. And the implications were cost savings. And so that is true. It costs less to provide MAID than provide social support and medical care. Okay.
On that slightly depressing note, I think we might need to sort of draw this to the end because we're coming up onto running about an hour. It's going to come up onto 9 o'clock, but it's 9 o'clock in Dublin. I'm not too sure what time it is anywhere else, but we're coming up to the end of the hour time that we have set aside. What I'd like to do is say thank you very much to Dr. Gaind for his very interesting presentation. A reminder that this webinar has been recorded and will be available, and that the website is Drs-say-no International. And also a reminder that there is an open letter there, which is open for doctors to sign. So please have a look at that and consider signing that. And also that Drs-say-no International run webinars in relation to assisted suicide and euthanasia. And there will be sort of emails sent around about future webinars. If you have any suggestions about potential topics or speakers, please make contact with Sinead or John, who can then sort of try and, because to get different speakers. I think it's just important to hear from different people, and it's very good to hear from different angles of things. So we have very good, eloquent Canadian psychiatrists this evening. So we're looking forward to hear from other people in the future. So I'm just going to say thank you very much to the organisers. And that's particularly Sinead and John, and also the technical people who have been involved as well in setting up the webinar. Thank you again very much to Dr. Gaind. And I'm going to say Ihawai, Kalasov, because it is nighttime here. And thank you all very much for attending. Goodbye now. Thank you.